Thank you for joining us for the 45th Annual AAKP National Patient Meeting. My name is Dan Abel, and I'm a small business owner in West Virginia. I've owned and operated my own small business for more than 35 years. The coronavirus pandemic has been challenging, both as a business owner responsible for employees and as a transplant recipient on immunosuppressive medication, running a business and trying to keep my employees, customers, and my family safe. I have managed kidney disease for more than 30 years and was on hemodialysis for 19 months before receiving a kidney from my sister Mary Beth over 25 years ago. I am proud to serve AAKP as a board of director. Being part of AAKP allows me to represent other patients with kidney disease and to impact national care decisions. I offer my patient viewpoints to many types of decision makers and policy influencers, including national medical experts and U.S. senators and representatives on key issues affecting kidney patients. As an AAKP member, I meet and interact with members of other kidney-focused organizations, as well as top pharmaceutical and medical technology companies working on innovations that will help kidney patients both in short-term and long-term. There's a tremendous demand among national leaders in medical community for patient insights, and I encourage all who are listening to join AAKP and help us get you directly involved in research and policy that will shape not just your future, but the future of thousands of patients you have never met. Today, I am pleased to introduce our session on disease management, advancements in dialysis vascular access options. We're honored to have two very esteemed presenters with us. Dr. James Meler. Dr. Meler is chief of the Department of Radiology at Baylor University Medical Center and a physician with Texas Interventional Radiology. He is also vice president of medical affairs at Benton, Dickinson and Company, a global medical technology company that is advancing the world of health by improving medical discovery, diagnostic, and delivery of care. Dr. Meler is a very strong supporter of patient care choice and believes that patients armed with the information they need to access care options, indeed intelligent consumers of their own healthcare. Dr. Meler joins us today to discuss emerging therapies in vascular access to enhance patient choice and BD's WavelinQ EndoAVF system for vascular AV Fistula creation. Dr. Meler, I turn it over to you.
I'm Dr. J.D. Meler, Vice President of Medical Affairs for Benton Dickinson. Today, in our conversation, we're going to discuss hemodialysis management, advancements in hemodialysis vascular access options, with our goal being to provide you more information about patient choices so you can strengthen your patient voice. Benton Dickinson is a global company. Our goal and our purpose is advancing the world of health. We are a leading global medical technology company uniquely positioned to improve both treatment of disease and the process of care. We're organized for impact. We have three segments. Our first segment is BD Medical. In that segment, we have things like diabetic care, an important element in a number of patients with end-stage kidney disease. We also have our BD Life Sciences segment. That segment handles lab testing. Almost every blood test in the world at some point comes in contact with the Benton Dickinson device. And then there's BD Interventional. On the top line there, you see peripheral intervention. That's my segment. That's the segment that provides all the devices for ESKD patients. Our commitment to dialysis access goes back decades. In fact, in 1975, we acquired the first commercially available ETFE graft to create an AV graft. Over the ensuing decades, we've brought to market a number of products to improve access and care for the dialysis patient. Our focus is on innovation. We create, we restore, and we maintain hemodialysis access for better care for patients. The goal of successful dialysis access is to provide the right access to the right patient at the right time for the right reasons. You can only do this when you focus on what the patient wants and what the patient needs. So our goals are to provide an access that's usable for hemodialysis, provides minimal complications, and ultimately the optimal patient experience. Many of you know there are three types of hemodialysis access. There's the AV Fistula, the surgical graft, and the hemodialysis catheter. What happens if there's a blockage in the AV access? At some point, there is in fact a narrowing of almost all AV access. This is caused by tissue and cell buildup along the walls of blood vessels, and it creates what's called a stenosis. That blockage limits blood flow, which prevents successful and efficient, effective hemodialysis. So there are options for AV access management. The first listed here is called Percutaneous transluminal angioplasty, or PTA. This is the most common technique for opening a narrowed fistula. These balloons are inflated in order to widen a narrowed vessel where the stenosis has occurred to improve flow and increase the efficiency and effectiveness of hemodialysis. Another option for AV access management is the drug-coated balloon. A drug-coated balloon is a standard angioplasty balloon that has been coated with a drug that assists with the reduction in the recurrence of stenosis. So the drug is delivered to the vein wall as the balloon is dilated, drug is implanted, and as a result, stenosis occurs more infrequently and over a longer period of time. In fact, our product, Lutonix, has demonstrated that it can provide a patient up to 114 more days of intervention-free hemodialysis. That's 114 more days that your schedule isn't changed or adjusted to deal with an occluded or a non-functional graft. Another device in our AV access management group is the Covera vascular covered stent. This is intended for treating narrowing or stenosis in the upper arm veins of patients who are dialyzing either by AV fistula or AV graft. For those of you who have an AV graft, the Covera covered stent is intended to treat narrowing at the location where your AV graft is sutured to your vein. There are several options for AV fistula creation. The first major advancement in AV fistula creation in over 50 years came when the product WavelinQ was approved for use here in the United States. So there are two types. Non-surgical is often referred to as endo or EndoVascular AVF. WavelinQ is an attractive AV fistula creation option. It is designed to provide a versatile endovascular AV fistula creation alternative to open surgery. Using two thin, flexible magnetic catheters and a burst of RF energy, physicians can create an endovascular AV fistula. The WavelinQ EndoAVF system increases the number of locations an AV fistula can be created while leaving future standard surgical sites available for subsequent surgery if needed. On the slide here, you see the four basic steps. First, we achieve access through minimally invasive sites in the upper arm. We align the catheters using the magnetic catheter bars, as you see in the picture. We activate, creating a hole, and then as you see in the final picture, you see blood flow going from the red vessel, which is the artery, into the blue vessel, which is the vein, which has now created an AV fistula, and the veins that are going back to the heart can dilate, mature, and ultimately be accessed for hemodialysis in the future. This is another slide, and it makes the point that this is, again, a non-surgical, minimally invasive method for creating an AV fistula. It also creates multiple cannulation options for patients. So by using an EndoAVF system, we actually not only increase the number of sites the EndoAVF fistula can be created, or the AV fistula can be created, we also increase the number of sites for cannulation. In addition, it has the added benefit of avoiding surgical scarring and minimizing arm disfigurement, which is associated with traditional surgical AV fistula creation. Again, on this slide, you see the minimally invasive access in the upper arm with one catheter going into the artery and one catheter going into the vein, and then being pushed downward where they create the fistula in the upper forearm. This is Christine Hernandez. We'd love for you to take the opportunity to hear her story and even ask her questions during a 30-minute symposium provided by BD on the topic of EndoAVF, or endovascular AV fistula. Please look in your agenda for the time that you can join and take an opportunity to hear about this exciting advancement in the creation of AV fistulas. Hemodialysis is not just for adults. Some children need hemodialysis. And this year, we were able to introduce the GlidePath 10 French. Adult devices are not intended for or able to be used in many pediatric patients. So we took on the challenge and took on the opportunity to innovate and create a hemodialysis catheter made specifically for children. Thank you very much for your time and attention. We appreciate the opportunity to join AAKP in providing patients information and strengthening their opportunity to understand their choices so they can strengthen their voices and engage themselves in their care.
Thank you, Dr. Meler, for an informative presentation. We appreciate your personal championship of kidney patient consumers and BD's commitment to the kidney patient community to advance and improve upon vascular access options. I'd like to now ask you a question as a follow-up to your talk. Dr. Meler, many of our kidney patients, myself included, are business owners and proud entrepreneurs. Can you tell us the business case for why it is so important to work with patients and advocates and how our preferences and insights help you build value into your products?
As a company, we are focusing on creating medical devices that are ultimately used with and for our patients. Patients are getting more involved with their healthcare, and more patients are advocating for themselves. We think it makes great business sense to bring patient input into our product design efforts, and it makes sense to understand what is important to the patients up front and what are their biggest problems and what are their biggest challenges. And from there, we create products that address their needs. We see this growing more and more as patients choose for themselves which products will best benefit them and which products best meet their needs. If we don't focus on patients and what they need, we know someone else will. Companies will need to get better at getting patient insights and delivering products that solve patients' problems to be successful in the future.
Thank you again, Dr. Meler, for your presentation and taking our questions. Now I'd like to introduce another outstanding patient advocate and kidney innovation leader, Dr. Shawn Gage. Mr. Gage received his designation as physician assistant from Butler University in Indianapolis, Indiana, and completed a 2-year residency in general surgery at Duke University Medical Center. Following completion of his residency, Dr. Gage was senior vascular PA and functioned as a vascular surgeon for 14 years within the Division of Vascular Surgery at Duke, where he had a busy vascular practice, specializing in complex hemodialysis access. He has over a decade of experience in preclinical and clinical research in vascular device development with new vascular technologies and was instrumental in the early clinical program of Humacrit Incorporated, a tissue bioengineering company and another strong ally of AAKP. Mr. Gage co-founded InnAVasc Medical Incorporated and serves as the Director of Clinical Operations. InnAVasc is a vascular graft company that spun out of Duke University and is developing a safe home hemodialysis graft, which protects from needle injuries and bleeding and is immediately usable for dialysis. Mr. Gage, I turn it over to you.
Well, hey, everybody. Shawn Gage here. Thanks a lot for having me. I really want to say thanks to Paul and Richard and AAKP for bringing me in to talk about this topic here. I think it's really important. I think it's really important for our patients to understand dialysis access management and how we got to where we are today and what we still need to do. So we're going to talk about dialysis management, advancements in dialysis vascular access options. So if we're going to talk about advancements in dialysis access, I'd be remiss if I didn't at least start with how we got here, how patients got to be treated by hemodialysis when they have kidney failure. And it goes all the way back to World War II when Willem Kolff developed the hemodialysis machine. And it wasn't until 1944 when he actually was able to successfully perform the first hemodialysis process. But his early machines, he had limited materials due to the war, and he actually developed his first hemodialysis machine using old laundry tubs, sausage casings, and a wooden drum. The issue around this, however, was vascular access. They needed a new site for vascular access every time. And the first patient died after the first 12 sessions because all of their vascular access sites were gone. So it really became, now that we had the ability to treat kidney failure with hemodialysis, now the issue was, what is that missing link? And it was the vascular access. How do we get access to your blood? So in comes the arteriovenous shunt. This was developed by Belding, Scribner, Doctors Quinton and Dillard in the early 1960s. And it was an external high flow shunt made of Teflon tubing that was connected directly to your blood vessels, an artery and a vein. Unfortunately, this issue was plagued with thrombosis and infection because, as you can see, it's an external shunt coming right out of your skin. But it really did allow a true launch for our renal replacement therapy era, because now this was the first type of access that was at least reliable, at least in the short term, but it was able to allow patients to get vascular access. So a few years later, in the mid-60s, these three wise men, Doctors Brescia, Cimino, and Abel, came up with the idea to create a more permanent vascular shunt under the skin, one that didn't have to expose the blood vessels to the outside world and expose patients to infection. And so Doctors Brescia and Cimino are nephrologists, and they had over time cared for patients from war conflicts that had developed acquired AV fistulas. When somebody gets shot or injured near an artery or a vein, they can fuse together and make a fistula. And so they thought, well, if that can happen from an injury, maybe we can do that surgically. And so they hired Dr. Abel to come in and be the surgeon and create the first arteriovenous fistula back in 1966. So the native arteriovenous fistula is often considered the preferred access method. You all, at this point, know very well about arteriovenous fistulas and the thought process around trying to make those work in most cases for vascular access. Typically, they're created in the non-dominant arm, but they can take 3 to 6 months to mature. And currently, this makes up about 60 to 65% of all dialysis access out there. So why are arteriovenous fistula preferred? Well, back in the early 2000s, there was Centers for Medicaid, Medicare Services cross-sectional study that was performed of people who had fistulas, grafts, and catheters. And when they did this financial evaluation, it seemed as though that fistulas were the cheapest to create and maintain, followed by grafts, and then followed by catheters. The problem was with this study is that these were assessments of fistulas that had matured and were working versus all fistulas that were created. And we'll talk a bit about that in the next slide. So this really was exciting for the kidney care community. And so the National Kidney Foundation helped to develop the KDOQI guidelines around vascular access. And at that point, KDOQI recommended a 65% AV fistula rate. And at that point, the fistula rates were extremely low and the graft rates were higher. And so this spurred the fistula first movement. So fistula first, this was, in my opinion, a bit of a head in the sand type of approach to fistula creation. It was sort of a one size fits all recommendation for all people to get fistulas first and foremost, because it was thought that they were better for all patients all the time. This did actually have a positive impact on increasing fistula rates, and it decreased graft rates. But because of this, as I'll talk in the next slides, we did learn about high AV fistula non-maturation rates. So there are really three big studies in the last couple of decades that we learned significant amounts about AV fistulas and their maturation rates. The Dialysis Access Consortium study in 2008 was evaluating Plavix versus placebo for AV fistula thrombosis. This was an antiplatelet drug used to see if it improved fistula thrombosis rates. However, from that study, it became apparent that only 44% of patients' fistulas were mature by 6 months. Followed by that, the Hemodialysis Fistula Maturation study in 2016 noted that by 9 months, only about 60% of fistulas were mature. And then a study in 2017 looking at fish oil and aspirin for fistula thrombosis and maturation noted that by 12 months, 50% of fistulas that were created had failed. And we see down there below, these are pictures of veins, and there's a native vein without any high flow blood associated with it there on the left. And when we introduce high flow blood by connecting it to an artery, what we want to happen is the vein to dilate and thicken a bit in what we call mature. But unfortunately, half the time, what happens is what you see on the bottom there, which is stenosis. And this is the negative response, the inward remodeling and cellular, what we call hyperplasia, or sort of overgrowth of that vein. And that happens for a reason. We were never meant to have a high flow arterial shunt directly into our venous system, which then overloads the right side of our heart and can then overload our lungs. Bodies were never meant to have that happen. And so this is a natural body's response to try to shut down that high flow shunt. And so we are constantly fighting against this natural process when we create arteriovenous access. So what we learned from the fistula first movement in these big studies was, okay, fistulas that work well, but not all fistulas work. And so we really started to focus on the catheter as well. So fistula first, but let's get our catheter out. And so fistula first, catheter last. Moving along to the access algorithm for today. Now we've started to think, okay, what's the right access for the right patient and at the right time and for the right reasons? And so there's still a strong focus on catheter avoidance. There's still a strong awareness that fistulas are good for patients that they work for, but we also understand that not all fistulas work. And so we're looking at different subsets of the population who may be better candidates for fistulas than others. And grafts are not all bad, and even for those that are first starting dialysis. So this has now opened up the paradigm again to let's just do the right thing for the patient, depending on the clinical situation, which is really what we're supposed to be doing in medicine. And just to follow up with one final fistula technology, everything I've talked about up to this point has been what we call in surgery using hot lights and cold steel. That's old-fashioned open surgery to create arteriovenous fistula for access. But over the past 5 years, there have been significant advancements in the creation of fistulas without the traditional open surgery. So what we call is percutaneous fistula creation. There are 2 companies out there now currently doing this and doing it very well. They have 2 slightly different approaches to doing this, but in the end, the bottom line is that a fistula can be made without making a cut in your skin and exposing you to traditional surgery. The idea here is that we could potentially increase the opportunity for more medical providers to create initial arteriovenous access for patients, as opposed to traditionally all patients having to wait for a surgeon to be able to do these surgeries. So going back to the beginning again, after the introduction of the arteriovenous fistula, which is extremely important in the era of renal replacement therapy, started to realize that we're only born with so many sites for access creation in terms of arteriovenous fistulas. We only have so many veins at the wrist and so many veins at the elbow to make fistulas, and then you're done with that type of access because we run out. So the thought was, how can we continue to continue to connect an artery to a vein by using some other means? And so back in the late 60s, the idea was developed to take your saphenous vein, that's a vein in our leg, and move it up to the upper arm and tunnel it under the skin and connect it to an artery and a vein. And this was really the first type of graft technology that we had. It was called the bridging dialysis fistula. And this process was actually done right at the almost exact same time by 2 different teams in Mexico and 1 in Australia. So what we're going to talk about following here is the AV graft technologies that have been developed over time up to current. And these are what we call prosthetic grafts. So these are non-autologous. They're something that is either made in a lab or made in a human or an animal that we'll talk about. And in terms of grafts, when we think about arteriovenous grafts, you oftentimes are really only limited by your imagination and artery inflow and vein outflow. If we can find artery inflow, vein outflow, and we have a type of conduit, we can get creative and put grafts almost anywhere on the body. Nowadays, the most common grafts out there used still from the beginning and to now are polytetrafluoroethylene grafts, or PTFE grafts. And that's currently makes up about 18% of all dialysis access in the United States. Back in the early 70s, after the bridging fistula was developed, they realized that, again, there's only so much vein tissue on our body that we can use for those types of bridging dialysis fistulas. So we needed some other type of conduit to hook up an artery to a vein. Along comes the development of the expanded polytetrafluoroethylene tube. It's a type of Teflon, but now it's expanded with air to make it sort of this white, fluffy material, tubular structure that has some structure to it so it doesn't immediately collapse. And it's what we call an inert material, which does not react with the body negatively. So it allows the blood to flow through without readily clotting, and the body does not typically reject this material, it scars around it. The initial PTFE grafts were developed for bypass. In fact, up until about 2015, all of our dialysis grafts that we use were really developed for peripheral bypass and were never meant to be stuck with dialysis needles. So the issues with grafts, unfortunately, they have poor long-term patency. And this really centers around what we've talked about with the veins as well for fistulas, is vein neo-intimal hyperplasia, or an overgrowth of the cells in the inner lining of the vein. And this causes a narrowing of the blood vessels, or a stenosis, and then that leads to thrombosis. And grafts, because they are a prosthetic material, are more prone to infections than fistulas. And again, they were never meant to be stuck with dialysis needles. They were never engineered that way specifically. And so unfortunately, the graft walls deteriorate over time with even routine needle use. And a study back in 2009 noted that at 1 year, approximately 75% of grafts had lost patency, which means that they stopped flowing. Sometimes that patency or that flow can be restored, and sometimes not. How have we tried to improve upon this graft technology over time? Well, as I talked about, many of these issues that plague dialysis grafts have to do with the flow and the development of that stenosis, or of the cells growing closed in the vein, as you can see here from these flow dynamics charts. So it was natural that many graft technologies really went after the ability to improve that outflow vein stenosis, to improve the turbulent outflow that really disturbs the cells in the vein wall. And we've had several technologies and ideas. We have grafts that are twisty or swirly, that swirls the blood or rifles the blood out so that when it reaches the vein, it is less disturbing to the cells. We've had grafts that have big cuffs developed on them so that it provides more room for those cells to grow closed and is less likely to shut the graft down. We've had grafts that have fancy double barrel flow systems so that when the blood flows out of the other end, it actually cancels out some of the negative flow disturbance signals, and it makes it a more quiescent flow for the vein to receive on the other end. And then we've also had grafts that have been fused with a stent to actually change the way that the graft is connected to the vein, so that rather than it be an end to side connection where the blood crashes into the back wall, it is a nice laminar straight flow from the graft right into the vein, as you see there in the middle. And that last graft that I talked about was called the Gore hybrid graft. This was, again, a fusion of a standard vascular graft with a vascular stent. Unfortunately, this graft is not available any longer. The intent, again, was for this to change the outflow dynamics to reduce the amount of stenosis developing in the vein. We didn't really use it for those purposes, but for me and my partners in a big vascular access practice where we manage several very complex patients, this was a really nice tool for us to be able to treat difficult to treat areas and to salvage otherwise potentially unsalvageable dialysis access. And so we really like this graft as a tool for that. It was just another tool in the toolbox for us to be able to help more patients. Unfortunately, as I said, the graft is not available any longer and we can't use it for those purposes. Companies have tried to make strides in providing what's called a thromboresistant surface or an anti-clotting surface. Two of the bigger technologies out there is Gore's heparin-bound technology or propatant technology, which binds a type of anticoagulant medication onto the inner surface of the graft and helps to prevent clot from forming. And as you see there, there's an example of an animal model, a short period of flow with blood across that graft seems to reduce some of the clotting that can happen on the graft surface. And then a similar type of technology, but using carbon rather than an anticoagulant drug, impregnated into the walls of the inner surface of the graft, helps to reduce platelet activity, helps to reduce the ability for platelets to clump up and adhere, which can lead to thrombosis. And so this was designed to reduce early graft thrombosis. Again, both of these technologies, it's difficult to determine how much of an effect they have beyond the first couple of weeks or first month, but they're interesting technologies to try to improve thrombosis. So from a bleeding and weeping perspective, there have been a few grafts out there that have been developed to specifically address that issue. And the weeping issue is something that happens naturally with many of the PTFE grafts. Because they're expanded with air, there are little pores in the graft that actually allow your serous fluid, that's the clear part of your blood, the water part of your blood and with proteins in it, to seep through the wall of the graft. And that's okay to some degree, but in some cases it can happen too much when we call it weeping, and it can lead to complications. So that issue, along with bleeding at the area where you sew the graft to the vein and the artery, or bleeding from where you poke the needle in for dialysis, are other big issues that they were trying to tackle with these grafts. And there are a few of them that have been developed over the years. Some of them are no longer on the market. But the two most recent developments are the Flixene graft and the AccuSeal graft there. They have two different types of technologies that allow them to bleed a little bit less than your standard graft. And certainly they have been pretty successful in reducing weeping. But in terms of reduction of bleeding, as you'll see on the next slide, we'll talk about the issues around self-sealing technologies. So as we set out to evaluate the ability for these quote-unquote early cannulation grafts to reduce bleeding at the puncture sites, we wanted to see what this looked like on the bench using a fluid that has the same type of viscosity as blood and the same systemic pressures as the average patient on hemodialysis would be experiencing. And when we poke these with needles, just a single needle poke, you can see from these still images how much fluid or blood-like fluid readily pours from those needle puncture sites. In these grafts, they were all punctured on the front wall all the way through and through to the back wall, because again, with dialysis grafts, it's very easy to do that and puncture through both sides of the graft. You can see down in the bottom right corner, there's a potential home hemodialysis graft in development that we'll talk about that may have some of the answers to these bleeding issues. There have been graft technologies to help reduce the scarring that occurs from the outside. So when a graft is implanted into your body, typically we don't reject it, but our body scars around it because it is a foreign body. There's been a company, Helionics, that has developed a technology that's called a microporous surface layer that helps to improve biointegration of the tissue. And why they do this? They thought that in improving the way that the graft incorporates into the body may improve the compliance or the flexibility of the graft, which then may have a positive impact on patency or how long the graft stays open, and may improve infection rates as well. And from a reduction of infection and from a perspective of patency or how long a graft stays open and functioning, there are technologies out there looking from a biologic perspective. And some of these have been around for quite some time, such as the Artegraft and the Procol graft. Both of those grafts are from cows. The Artegraft is the carotid artery or the neck artery of a cow, and the Procol vessel is a mesenteric vein, or one of the big veins in the abdomen from a cow. And then we have the OmniFlow graft, which is actually a mesh tubing that is inserted into the back of a sheep, and the sheep has the ability to heal around that tube and deposit collagen from the sheep around that tube. And those tubes have been successfully implanted in humans and have worked as well. And then in the bottom right is one of the most recent technologies, the Humacyte vessel, which is a human bioengineered tissue vascular tube that can be used for hemodialysis access or for peripheral bypass or even potentially vascular replacement for traumatic injuries. All of these vessels really have the goal to be more like the human tissue, more like your own vein. And so therefore the potential to heal into your body better and perhaps resist infection better than typical prosthetic vascular grafts. And from a thoracic venous pathology standpoint, this is something that's an extremely important issue in hemodialysis access. This is what we call central vein occlusion or central vein stenosis. Unfortunately, this is something that happens with patients who are on hemodialysis, mostly because many are exposed to central venous indwelling catheters. Those are our dialysis catheters that lie in the central veins, and they vibrate around in those central veins and irritate the vein wall. This, in conjunction with the high flow blood that may flow through those or flow across those veins because we have a fistula or a graft in our arm, really irritate those central veins, and they can grow narrow or they can grow shut. And if this happens, it doesn't matter what type of vascular access you have, it absolutely will not work. In comes the HERO graft. This stands for a hemodialysis reliable outflow. And it's a really nice name because it often does save the day for patients who have totally occluded or significantly narrowed central veins such that their access won't work. And really what it is you can see there the white component is a standard dialysis graft, and the gray component there is what we call the venous outflow component. And this is really a long silicone stent. It's a customizable length, so it can be any length that we need it to be. It's very flexible, and it never grows into your body, so it actually can be removable. And the beauty of this is that if we can get through those central vein narrowings or occlusions with different types of techniques that we have, and we can put that silicone stent through there or the outflow component in there, it leads right back to the right side of your heart and allows you to have normal flow from any type of graft or a fistula. I've hooked these to anything. I've hooked them to fistulas, I've hooked them to standard dialysis grafts, I've hooked them to early cannulation grafts, and I've hooked them to those biologic type grafts that we've talked about before. This is a technology that really has helped to revolutionize vascular access for hemodialysis over the last 20 years. So as you can see, we've talked about a lot of different vascular access technologies that have spanned over 50 years. We've talked about ways to make access directly to your bloodstream. We've talked about biologic vessels and biologic grafts. We've talked about changing the flow dynamics so that it reduces the amount of stenosis. And there's even drug therapies that we haven't even talked about that have tried to improve graft technology. But what we haven't talked about is technologies that have been aimed at preventing against things like this: back wall injuries, hematomas, localized graft or fistula infections from needle puncture sites or from vascular sheath sites from when we have angioplastic procedures or declotting procedures. Or most importantly, graft breakdown and degradation, which leads to dangerous bleeding events or pseudoaneurysms that can become infected. Again, these grafts that we use most commonly were never engineered specifically to be stuck with dialysis needles. They were engineered to be blood vessel replacements. And so we asked them to stand up to repetitive needle puncture 3 times a week, or if you're on home hemodialysis, 5 or 6 or 7 times a week. And this is something that these types of grafts cannot withstand over time. We've not developed anything that significantly prevents against things like exsanguination or bleeding to death from your vascular access site. Again, this is an issue that happens all too commonly every year with several patients, and we should not Patients should not have to risk this in order to receive their hemodialysis treatment. So this is just a simple animation of our typical standard grafts. And what you can see from the animation here is that the needle very easily not only punctures through the front wall, but very easily through the back wall. And this is a common complication that patients with dialysis grafts and fistulas suffer. In addition to that, over time, as I explained before, these grafts start to break down from multiple needle cannulations. And not only does this lead to bleeding and pseudoaneurysms, but it also leads to a roughened surface on the inside of the graft that allows the platelets and blood to clump up on that area and potentially develop clots. And so over time, instead of these grafts being a very nice, smooth and shiny 6mm tube on the inside, they end up becoming a very irregular 3 or 4mm tube on the inside, which makes it even more challenging to stick appropriately. There have been no technologies from a vascular access perspective that focus on home hemodialysis either. And what we would like to do is get to a point where patients can be dialyzing at home in the comfort of their own surroundings and safely without having to have issues around anxiety and fear of needle punctures and complications. And shouldn't being able to stick yourself at home or having a family member at home be easier to do and less anxiety provoking because of a potential complication or bleeding? No technologies have been developed around this either. So we're going to talk very briefly about InnAVasc and the graft that we're developing to help to alleviate needle-related complications and to help promote a safer, easier access for home hemodialysis. So the InnAVasc graft solves really 3 main issues around dialysis, and this is for both home dialysis or in-center dialysis. From a needle protection standpoint, as I showed you before, a needle very easily passes through the back wall of a standard dialysis graft. However, the InnAVasc graft has a back plate built right into the cannulation zone that does not allow the needle to pass through the back or the side walls, therefore alleviating those types of complications. From a bleeding perspective, again, just as the needle goes through the back wall very easily, and when it comes out of the front wall, it allows blood to leak out of those puncture sites very easily. The InnAVasc graft has a self-sealing technology so that when the needle is removed from the graft, it completely seals up and there's no bleeding from the site. And from a home dialysis perspective, and access perspective, being able to identify your fistula or graft can be very scary and anxiety provoking. And it can be very difficult to actually get the needle into the correct spot so that you can receive your therapy for the day. The InnAVasc graft has 2 very easily identifiable targets for you to be able to identify and stick the right site every time. So just to review, the InnAVasc graft is a standard graft, but we have incorporated these what we call cannulation chambers that provide a durable and easily identifiable zone for the technician or for the patient or family member to be able to identify where's the right spot to stick, with the incorporated back plate that does not allow the needle to exit the back side or the side of the graft, therefore reducing complications and making it more likely that the patient can receive their intended treatment. And from a self-sealing perspective, the materials that we use do not allow bleeding to occur, whether it's from normal use and puncture of the graft over and over again, or it can help to prevent issues and bleeding around accidental needle dislodgements that may happen. And so in contrast to the last animation that we saw, where the needle easily passes through the back wall of the graft and leads to bleeding, the InnAVasc graft, very simply, does not allow the needle to pass through the back wall or the side wall. And when the needle is removed from the front wall, it does not allow bleeding either. And so just a quick background on some of our early human clinical data. We've used our graft in 32 patients to date. And what we've learned from a positive conclusions perspective is that implantation of our graft is safe and feasible, even though it has those slightly larger cannulation zones. There could be some question around the ability to implant the graft or to feel the graft, and we've had very positive results with that to date. We've also learned that the graft can be used immediately for hemodialysis, and in fact, we've had a couple of cases where we've even punctured the graft on the operating room table in order to perform angiograms to check the configuration of the graft and make sure that there were no problems with the way it was connected. And so the graft can truly be used immediately without fear of bleeding. And very importantly, the cannulation chambers worked as intended to prevent needle injuries, back and sidewall punctures, any sort of clinically significant bleeding, or those pseudoaneurysms or deformation areas that you see on grafts and fistulas. To date, we've had over 11 patient years of patency and use of our graft, and that's over 4,000 needle cannulations. And over that time, there have been no needle-related complications to date. So shifting gears to the home hemodialysis front. Last year, there was an order from the White House in Health and Human Services on advancing American kidney health. And there were three main goals that came out of this. And number one was to reduce the number of Americans developing kidney failure by 25% by the year 2030. Number two was having 80% of new dialysis patients to either receive home dialysis or to receive a kidney transplant by the year 2025. And the third was to double the number of kidneys available for transplant by 2030. Number two is a huge opportunity in terms of the movement towards home hemodialysis. And this is based on significant amounts of data that we have from the past decade or more of the benefits of receiving hemodialysis at home, mostly because of the fact that you're able to receive dialysis 4, 5, or 6 times a week, which dramatically reduces the complications associated with hemodialysis and makes patients feel a whole lot better and improves quality of life. And so a lot of the barriers around home hemodialysis in terms of financing, in terms of reimbursing, in terms of coverage from nephrologists and logistics with the large dialysis organizations have started to improve with the executive order. But there's still a significant issue around fear of self-cannulation, needle complications. What if my needle falls out? What if I can't access my graft? And these are very significant barriers to the adoption of home hemodialysis. And this is something that we believe that we could be the potential missing link to improving the transition to home hemodialysis for more patients in this country. So let's talk about our training process at this point. So at this point, we have to roll out a process to adequately train our dialysis technicians for in-center use. And so we just wanted to talk about what we've done from a training process and how we've built it so that it's easily transferable to dialysis technicians and nurses, but also so that we can make sure that everybody has the proper materials that they need in order to safely and reliably cannulate the graft. And again, we built the graft to be easily identifiable, easily stickable, but because it is slightly different than what technicians and nurses are used to using, there has to be a training program with that. So this is just a quick section about how we have built the training to date, and we're still improving upon this training. But what we've done is we've built a series of materials such as written cannulation instructions with animations that show the technicians and nurses the process by which to identify the graft and then how to stick it. And we've also made a corresponding how to cannulate the InnAVasc graft animation that shows step by step. And we've made it so that not only is it easy to access for those in the dialysis units trying to access the graft, but if a patient were to be admitted to a different hospital where the graft has never been seen before, there needs to be a way to communicate that to the staff trying to use the graft. And so therefore we've made this video available via this QR code that you can snap a picture from our cannulation templates or from our cannulation instructions or from the wristbands that our patients wear, and it can be launched on any smartphone or any computer. And the cannulation template is something that we go over in the animation. And just wanted to explain quickly about the premise of that. The cannulation template really is just to enforce our current behaviors and what we've trained for in hemodialysis access, which is to use a standard rope ladder technique. What we don't want to do is do area cannulation or cannulate in the same area over and over again, because it doesn't matter what kind of graft you have or what kind of access you have, you can wreck the skin, cause infections, and then you've lost your access. So what the cannulation template does is it just encourages what we've already been trained, is to continue to use the rope ladder technique. And in fact, the size of our cannulation zones actually allow for a full month of hemodialysis cannulations, at least from an in-center 3 times a week perspective, before you ever have to come back and puncture in the same zone ever again. And so we really believe that this will improve the longevity and the safety of using the graft beyond its current properties that we've engineered into it. So I just wanted to end by noting the process that we've used to put our patients and our stakeholders first. So from the beginning, we've tried to put as much thought in this as possible from the patient perspective. We developed this graft because of the injuries that patients had and were suffering from routine needle punctures, even in the hands of experts. And so what we've tried to do over the course of our clinical studies is make sure that we're reaching out to the end users, the stakeholders, such as the dialysis technicians and the nurses that are using the grafts, to survey them on how they feel about when they're using it, what's good about it, what's bad about it, because we know that there's always room to improve. And in addition, in our clinical trials, we're also surveying our patients about their vascular access specifically, using the SFVAQ questionnaire that again is specific to vascular access and not just hemodialysis or kidney failure, which really doesn't tell us much about the vascular access experience. And so this is all very important information that we're continuing to compile so that we can improve upon functions of the graft. And as we look to the future, to move this graft into the home setting so that more patients can transition to home and receive better hemodialysis therapy, we've started to build a training program around home hemodialysis. And what we really want to do is we don't need to reinvent the wheel here. There are training programs out there. But what we want to do is put together a package that is one solid package specific to the InnAVasc graft that gives patients everything they need to know about home hemodialysis, how to identify and cannulate the InnAVasc graft and how to use it safely, and how they can reach out for questions and receive help anytime they need it. So this gets into a project that we're about ready to embark upon, which is really pulling the patients and utilizing the patients from the very, very beginning. And so we're putting together a program where we will work collaboratively with AAKP, Home Dialyzers United, and we hope that we'll also be able to work with the National Kidney Foundation on this as well, to be able to truly pull the stakeholders. And from the AAKP, we'll be looking at chronic kidney disease patients, and end-stage renal disease patients. Home Dialyzers United, we're going to look specifically at the home hemodialysis patients to be able to ask them specific questions. And then from the National Kidney Foundation, we'll hopefully be able to leverage them to question their clinician cohorts so that we can truly have a well-rounded program. And at the end, when we take all of this information in about what patients really need in terms of developing a home hemodialysis program, what they need from a training perspective, we will then be able to put this all together in one comprehensive, informed training program. And we're really excited about starting this project. And we really hope that that all of you out there would consider helping us with this as well. We really want your input. We really want this to be the best for the patients. And again, I just want to say thanks to AAKP for reaching out and allowing me to be a part of this really important meeting. You know, again, putting the patients first is where this all came from, is where it was all born in the operating room, with all the frustrations that we have with trying to fix dialysis access, and back in the clinic where patients are frustrated from injuries and setbacks. We want to make this better for patients, and we're at a point in time where we have to do this. In the last 50 years, we've really not come that far with vascular access technologies. We have to get to the next level. We have to make it safer for patients, and we have to get more patients home for hemodialysis therapy. Thanks.
Thank you, Mr. Gage, for your excellent presentation and very informative lecture. Now we'd like to follow up with a question in reference to your business. Mr. Gage, as an entrepreneur and medical professional, can you tell us what made you seek out AAKP in kidney patients at the very start of your planning process for a new vascular access innovations?
Yeah, that's a really awesome question. And I really think it kind of gets back to how I ended this whole thing. This is not for me. It's for the patients. It's for the end users. And I think that the majority of technologies that I've put my hands on out there, I do not believe that it started with the patient's voice first. I think that oftentimes it starts in a vacuum with engineers who are very smart people. But in the end, this gets back to what do the people need? What do the patients need? And just having that having that connection with my patients in surgery and in the clinic and in the operating room, this really all comes back to. And I knew that I could come to AAKP, knowing AAKP's mission, and would be willing to help me with this project going forward. And so, this is exactly why I'm here, and so I'm glad that I'm able to talk about this today. And again, can't thank you enough, and look for your help out there as we continue to make this better for other patients.
Thank you, Mr. Gage, and thank you, Dr. Meler. We appreciate both of you sharing your time, insights, and expertise with us. We again applaud you and thank you for your commitment to advance patient care and patient choice. It's individuals like the two of you who demonstrate the courage of innovative that move care options in the right direction and away from the status quo. Thank you again, and thank you everyone for joining us.